So, good morning everybody. I would like to thank God Almighty and ISL West Zone Scientific Committee members for this opportunity to talk to you on free of AVF evaluation of the patient. So, a nephrologist who is planning to create AV fistula need to have a strategy in his mind. The wrist AV fistula first. If that is not possible, then elbow AV fistula is a second choice. And if that is not possible, then catheters or AV graft. So the nephrologist who is taking care of pre-dialysis patients and dialysis care should take the responsibility of educating the patient, the ICU nurses and technicians, lab technicians particularly, to preserve the venous system of the CKD man as the real estate. So one protects his real estate. So venous system of the CKD person is like a real estate. So he should be educating the patient per se. Patient is the best person who can tell technicians, laboratory people, ICU, not to cannulate or not to put it and get blood from these veins. And then there are 5 requirements for a good AV fistula: the healthy artery, healthy vein, and healthy heart. Apart from these, appropriately sized and shaped anastomosis and patent central veins. These are the 5 requirements of a good AV fistula. So, planning a AV fistula should begin a day prior to surgery. There are 4 points in planning. 2 before the date of the fistula and 2 on the day of surgery. So, site of the AV fistula needs to be decided upon by the nephrologist, depending on the patient comorbidities and the vascular status of the individual. The type of anastomosis, there are 4 types one has to choose from: side to side, end to end, end to side, and side to end. Depending on again the site where you do fistula. In a mid-arm fistula, you will be better off with doing side to side, and wrist you will be better off doing end to side. So you need to choose the type of anastomosis. And then you need a combination of artery and vein. This is a very crucial thing. Particularly in elbow, you have options of choosing a brachial artery or a proximal radial artery, and cephalic vein, antecubital vein, basilic vein, or the perforator. One of my seniors used to give us a jokingly used to say that creating an AV fistula is like a marriage, organizing a marriage of your daughter. So the nephrologist becomes a father of the daughter, and the vein becomes the vein is the daughter, and the artery is the husband. So the long-lasting marriage is decided or dependent on the girl's liking for the husband. So a vein has to choose which artery it has to go for a lasting fistula, because if you pull or push or force a vein on some artery, you can make a fistula or anastomose it, but it will not last long. And then the last point on table you need to plan is tying efferents which are not useful for cannulating after the fistula is made, because if you create a antecubital vein fistula with brachial artery, and then the basilic vein is left to flow, then you will create unnecessary load on heart. So avoiding load on heart when you cannot cannulate the basilic vein, and then you can have a possibility of steal on the downstream circulation, or the vein which we are supposed to cannulate may not dilate as full because it has got outlets more than desired. So there are 2 main approaches for creating an AV fistula. Surgical approach we are all doing in India. In Europe, currently they are doing the percutaneous endovascular AV fistulas. There are 2 techniques: the Genesis device and the Barnela device. Basically, next decade nephrologists in India or in Aurangabad are likely to buy these devices and do percutaneous AV fistulas. it's like a PTCA versus CABG. Open surgical approach for fistula is like CABG, and PTCA is like this thing. We won't go in details of the method of this. The timing when you should do fistula is, I told you earlier, fistula first and catheter last should be the strategy by a nephrologist. So at least 6 months to 12 months before anticipated beginning of dialysis, you should create a fistula. 15 days, minimum 15 days for healing of the wound, 6 weeks for maturation of the fistula, and in case you need some repair of the fistula, another 3 to 4 months. So 6 months minimum and 12 months more for the creation. Another KDOK guidelines suggests eGFR less than 30 ml, the time has come to prepare a fistula. Then the physical examination of the patient who is supposed to get AV fistula by a nephrologist, you need to understand the patient comorbidities, as there are two consequences of nephrologist creating fistula. One is a primary failure, secondary failure, or failure to mature. You have to face this music of these three failures. And then second music is of creating a catastrophe, rupture, bleeding, thrombosis, closure of fistula, or infection. So to prevent these, you need to analyze your patient before planning for the fistula. Elderly persons and diabetes, they are known to have negative influence on maturation of the fistula. Obese people, heart disease people, and peripheral artery disease people, they are unlikely to dilate their veins, so you need to be taking special precautions for different surgical techniques in creating a good flowing fistula in these people. Catheterized person in India, we rarely get catheter first, no pre-dialysis care patients, CKD patients. And these patients can be managed by two ways. One, if a catheter is on the right side, you just omit you choose the left hand for creating an AV fistula. And if the person has been catheterized on both the sides, then you have to study the central veins before you take the patient for, either by the Doppler or by venography or by CD angiography. The possibility of creating an AV fistula with catheter-induced central vein stenosis is a real mess for post-fistula, very high pressure circuit, and then the swelling of the arm. The thrombosis, possible thrombo prevention of the AV fistula, it needs to be planned, and the dehydration, hypotension, particularly in salt wasting CKD people, these are the possibilities. So you need to prevent these. And then the tendency of clotting in COVID positive patients, recovered COVID people or post-COVID, long COVID people. These people have hypercoagulable situation. And other hypercoagulable disorders are Aplar syndrome, lupus. These people really will have repeated primary failures, secondary failures, and need extra precautions. So, physical examination of a patient who is waiting for AV fistula includes 4 things: the artery, vein, and the skin on where you are supposed to operate, and heart or circulation of the person. So, skin, I told you, non-dominant arm, the arm which is opposite to the catheterized person should be chosen, and then by inspection you can see the health of the skin, thickness of the skin, color of the skin, all those factors are important where you are supposed to incise. The rash, the corporate spots, telangiectasia in elderly people, multiple scars and skin diseases, these will create problems in taking incision, and because the main vessels, particularly in elbow fistula, are just below the skin, and if you cut the diseased skin, and if that gap, you will have a mess after creating fistula on such people. And then you need to examine also the skin of the patient who had infected perm gas or infected central DLCCs or the scars. Arterial system evaluation is very essential or crucial, and from the character of the peripheral pulse, you can imagine the circulatory disorders. The water hammer pulse indicates aortic regurgitation, pulsus miscreans indicates aortic valve disease, pulsus alternans indicates cardiomyopathy or heart failure. So all these circulatory disorders need a cardiology opinion before you take the person for fistula. Allen says we all know how to do it, but it basically it tells you the patency of both the arteries, and if you operate on it, if you happen to close the radial artery for some reason, and the ulnar artery has a peripheral ischemic disease or atherosclerotic disease, you will end up with gangrene of the toes, fingers. To prevent that, you have to record the function of ulnar artery and the radial artery by doing this test. Checking blood pressure on both the arms. The difference between two arms, systolic pressure more than 20 millimeter of mercury, indicates that the person has some arterial disease. So this is a very crucial thing. 20 millimeter of mercury difference. And then color Doppler of the arterial system. Next topic is on how to map the vessels. We won't go in details of that. But three things: diameter of the artery which you are supposed to intervene in period fistula on, more than 2.5 or 2 millimeters. Then the flow and the calcification of the artery. These things are easily picked up by color Doppler. The spectral Doppler, you have three types of waveforms: triphasic, biphasic, and monophasic. These are essential to record because a triphasic AV waveform, arterial waveform, is indicating the laminar flow in the arterial circulation, and the disturbed circulation flow or turbulent flow is indicated by the monophasic or biphasic wave fronts on the spectral color Doppler. So you need to talk to the sonologist for surface marking of the radial and ulnar arteries, and the brachial bifurcation in some cases is above elbow. So if you know beforehand that the bifurcation is higher up, you will not search on the brachial artery for a long time. And then the wave fronts I told you earlier are very similar in ulnar and radial arteries. The algorithm need to be really recorded for consumer court protection against nephrologists, because you need to record on the palpable pulses in all possible areas, then pulsatility and resistivity of the pulse. In case you fail, primary failure or secondary failure, somebody can sue you, and then if you have maintained this algorithm and record it as cardiologists and cardiothoracic surgeons do, to give you a arterial graph and where are the blocks and all those things. So that you should be giving to a person who you are doing a fistula on. And then the additional information of diameter, the calcification, the vascular compressibility, pulsatility, resistive index, all those parameters next speaker is going to speak to. And then this picture like this can help you protect in case if somebody develops a catastrophe, with markers, a pen, and giving you the sites where you can do the fistula and the veins. Because there is anatomical and physiological variation in the individuals, the veins may not be like this in all the patients. In venous system, you need to evaluate whether the person has edema of both the arms. If the are edematous, you need to dialyze him, get a dry weight on him, and then plan for AV fistula. If you have unilateral swollen arm, then possibly you have a central vein obstruction or filariasis or mediastinal compression syndrome. You need to evaluate what is the cause of unilateral edema. Then collaterals on the chest or neck indicates again those same things and needs evaluation. Evaluation of veins by palpation is the real key, because feeling a cord-like vein, brachial vein, basilic vein or cephalic vein, you should avoid those. The vein which is clotted looks good from outside, but if you palpate, you will feel like a cord. Normal vein should be compressed. It should not be felt like a cord structure. And then the palpation of the veins where catheters and punctures were made, there you will get a button-like feeling, and all those are evidences that you had been catheterized. And then majorly JVP is another essential thing by nephrology, because heart, if it's failing, will have bad effects on the fistula. The most important test for doing a success in fistula is a tourniquet test where you can see which vein, I told you earlier a marriage concept. So which vein is willing to marry which artery is obviously seen by a tourniquet. And it is a simple test. If we raise the blood pressure of the sigmoid or tourniquet to 80 to 90 milliliters for almost 10 minutes, and veins will be obviously seen, and you will know which vein to marry which artery. In the venous ultrasound, we won't go in details. Next speaker again. Algorithm for veins, again, that will protect you from medical legal cases. Same picture here. You need to record diameter, you need to record the patency of central veins, you need to record the most suitable diameter of the vein, and compressibility, distensibility, all those factors. This is a picture of a patient who developed a swollen, painful hand with a pulsatile swelling and blisters on the thumb, and then the patient was re-explored, the distal branch of the cephalic vein was tried, and then the hand was normalized. So the lesson learned from this case was that you should tie up the efferents which are not essential for, useful for cannulation. And distal vein, side to side anastomosis we have stopped doing now, but sometimes we do side to side for mid-arm fistulas. Then this is another case where a small 8-year-old boy underwent AV fistula under local anesthesia, with his mother being allowed to in theatre with changing clothes and all, holding the baby, the boy's head, patting him and pacifying him with a loving, caring hand, and he allowed this AV fistula under local anesthesia. Otherwise, we were ready for the backup of GA or regional anesthesia. So lessons learned from these three AVF fistulas need to be twofold. One, you need to prevent primary AVF failure, secondary AVF failure, or failure to maturate. A good flowing fistula, but it is not useful to cannulate, is a terrible situation. I have made fistulas in a patient with brachial fistula working, but we had to do a radial fistula again, because it was not usable. So this thing should not be avoided. Then examples of catastrophe. Catastrophe we need to prevent, and if we do a pre-AVF planning and evaluating the person, then probably we will prevent that. So thank you.